Hi, my name is Ryan Kane, a third-year internal medicine resident at Oregon Health and Science University, presenting the poster Cardiopulmonary Compromise in the Preoperative Assessment. Please see my co-authors below. We know that multimorbidity is rising in our aging population, increasing our surgical risk. However, a holistic approach to the patient with a comprehensive preoperative assessment can help mitigate that risk. Here we present a case of a 67-year-old man with tobacco use disorder, class 1 obesity, and untreated OSA, presenting at the pre-op clinic prior to planned basal cell carcinoma removal and reconstruction. He'd noted 6 to 8 months of increased left ear pain, bleeding, and discharge, with a 1-month increase in fatigue, dyspnea, and exertion. He denied chest pain palpitations or dyspnea arrest, though laid down spontaneously during the H&P secondary to subjective dyspnea. He had an uneventful prior excision in 2018, and his vitals in clinic showed a heart rate of 77, normal tension, mild tachypnea of 17, hypoxia at 94%, and an elevated BMI. He was in mild distress with an myelopathy of 4, normal neck range of motion and dentition, and a normal cardiopulmonary exam with no JVD or lower extremity edema. His ASA risk class was 2 and had a low risk of major adverse cardiovascular events per the Gupta risk calculator. He had a leukocytosis to 15, and his ECG in clinic in Figure 3 compared to his prior that year in Figure 2 redemonstrated an old inferior infarct with left axis. However, he had new T-wave inversions in leads 3, V1, and V2. It was decided to pursue same-day TTE with a right ventricle that was mildly enlarged with a decreased systolic function, new for him. And so we decided, with multidisciplinary discussion per the surgeon, anesthesia, and pre-op clinic providers, to pursue outpatient expedited cardiology evaluation first, prior to procedure. However, the patient clinically worsened, prompting recommendations to go present to the ED, where our differential diagnosis could be worked out more quickly. He redemonstrated hypoxia to 88 now, with an elevated NT-proBNP, an unchanged ECG, normal trope, again negative COVID, but multifocal ground glass opacities on chest X-ray concerning for pneumonia. The inpatient admitting providers, however, noted an elevated Wells criteria and PERC rule, hinging mostly on their concern for PE. The CTA showed a bilateral main pulmonary artery embolism with right ventricular dilation concerning for heart strain, consistent with submassive PE, with extensive left lower extremity DVTs per the duplex ultrasound. He was started on anticoagulation and discharged on apixaban with plan for repeat risk stratification prior to procedure. This case really highlights the essential need to have a developed preoperative framework upon which to structure your medical decision-making. Also, it's important to understand the significance of our initial data that we can obtain in clinic and use risk calculators to help determine whether or not additional testing is needed. Our multidisciplinary care team can really be an essential piece of that determining factor in order to provide that safe and successful surgery, which is the goal for all of our patients. In this case, these subtle ECG findings in acute PE with the T-wave inversions and that T3 added to the S1Q3 really should have prompted us maybe a little earlier to consider PE with this new TTE finding of right heart strain. However, it was really that clinical judgment by the inpatient admitting providers, shown by the Wells criteria positivity, that prompted them to pursue the additional testing. Thus, not only is it important to have this comprehensive preoperative framework and have the ability to have that multidisciplinary care coordination rapidly for our patients, but it also behooves us to understand the subtle findings in our data, particularly these ECG findings associated with acute PE. It also encourages us to use our risk scores to help stratify risk, but in this case, his risk was low, but it turns out his clinical risk was high with his acute PEs. So that clinical judgment really is an important factor and counterbalance to all these decision aids and tests. I really appreciate your time and the opportunity to present this unique case. Thank you very much.